And you've also branched out to be somewhat of an entrepreneur and done opened some of your own private businesses as well. What led you to do that?
For me, I actually am a very entrepreneurial guy, and I'm always looking for business opportunities. And for part of them are just extensions of what you do, doing the research thing, which we've been doing for 20 years. And now we're just expanding. We've taken on a partner and we're expanding it across the country. It just grew from something we want to do. We want to look after GI in the western part of the city. So a bunch of us got together. I would say if I ever had a strength, it's somehow getting all these guys to sort of work together from multiple hospitals, multiple approaches. That's whether it was the OAG, whether it's TDDA, whether it's the Vaughn Endoscopy Center. For some reason, I've been able to herd the cats, as they say, and get people, for the most part, working together to build things. And so the research company grew and led to us wanting to do endoscopy outside the hospital, partly for the research perspective, partly because when we started this, 12 years ago or 13 years ago, we all had 9-10 month year waiting lists with nowhere in sight. The hospitals weren't increasing endoscopy time. And we all decided to look after patients. We had to do this. We always thought that the government would step up to the plate and help us fund this, which they never did. And that's always been a disappointment. My biggest disappointment when I did the CCO stuff. But nevertheless, we're here and providing, in the clinics, we provide 160,000 colonoscopies a year for the province. But if that didn't exist, I don't know what we would do, plus the gastroscopy. So it's over 200,000 procedures done by the docs, paid for by the docs on behalf of the patients of this province that really is given no mind. They just say, thank you, what are you doing for me next kind of approach. Anyways.
So, that's an interesting point that, obviously they've developed into a critical part of the healthcare system, these private clinics, obviously in a public healthcare system. What do you think has led to that gap in understanding from the government of the role that private clinics play?
I don't know that there's a gap in understanding. I think that's I think they understand. We've been, in terms of many capacities, have made multiple submissions to the government about the benefit of these clinics. And, listen, we started the college's assessment program and developed a quality framework and rules for clinics that clinics have to abide to. So again, we did that probably 7-8 years ago when we started that. And now there's a whole OHP system that's accredited, monitored, accountable, and there's always things that you have to follow, much more stringent than the in-hospital rules, actually. So we started that. I can't remember when I was on that committee and did that a long time ago, and that's just started. So we've built a very strong program. The government knows we've built a strong program. And when I was at CCO, we had made a whole proposal and had them, in fact, switch from OHPs to IHFs, independent health facilities, and with the goal of getting them accredited and funded. And, we had it all ready that's what I was doing partly when I was the endoscopy lead. And it was supposed to be implemented April 1st of 2014. And on March 31st of 2014, they said, no, we're not going to do this, after building the whole program with most of the facilities going out, paying consultants to make sure they met all the criteria that they needed to for IHFs, and the government pulled the plug. And to this day, most have still stayed. Some have gone out of business because the business model is very difficult and very challenging, only to come around where now it's probably more important than ever to have these outpatient clinics, because we're going to start, and most of them have started opening back up, where hospitals are still at 30% capacity. And to make up 3-4 months of backlog, the hospitals are going to have to go to 130% of capacity, which they won't be able to do because of potential funding issues, which isn't true because they haven't been doing any of the cases which they've been funded for, so they still got to do them. But more importantly, staffing. Like, you just can't get, you want to open up another room, which we fortunately have, you need 3 or 4 more staff. Well, you just can't get them overnight. They're not available. We don't even have our existing staff because they've been redeployed. So we have to get back existing staff. Then we would have to hire staff. So we're hoping, in fact, to even have an opportunity of using these clinics, if for nothing else, in the transition time, to try and help deal with the backlog, because they're all awesome, excellent programs, excellent facilities that are all, monitored and approved by the government and should be used to help us get out of this hole that we've unfortunately found ourselves in because of COVID.
So I want to go back to the role of, private clinics. You touched on a little earlier, the role of the clinic in the healthcare system, and, how the government perceives it as an integral part of the system, just like long-term care should be, and other aspects. What is missing there? What is missing with, the realization that in a public healthcare system like ours, there's also an important role to play with the private entities?
So, first of all, there needs to be acknowledgement of it by the government. Really, there's just passive they don't even acknowledge that they're there. They just say, someone make sure they do it properly, but that's all we want to know from them. Yeah. If you look at, I don't know what CCO is anymore, but Ontario Health and the CCO group of it, they've been lukewarm to being involved with the clinics or not. But in the end, they've not pushed to get them funded. When the FIT program came, they talked about doing them there, but they weren't going to pay the clinic. So how could you ask people to do the most complicated procedures and not pay them for it?
Right.
So there's just been this lack of willingness to pay clinics technical dollars. It's not anything more. But without the large volume of procedures being done in clinics, I don't know where we would be from an endoscopy delivery point of view. We wouldn't. And the number of people who have had cancers would have been higher. There's just no way that those polyps that we're taking out in the clinic, and I'm not talking about the 5 millimeter polyps, but all the other ones we're taking out aren't making a big benefit to the system and changing the incidence of colon cancer down the road. Whether we can say that there's actual trial evidence, because there's not yet, there won't be trial evidence about colonoscopy in a long time. There's no way that taking out all the polyps that have been taken out in the clinics that would not have gotten done in any timely manner in the hospital hasn't made a huge difference.